Okay. We welcome you to this international webinar series 3 on gastroenterology. We have great pleasure inviting. I am Dr. T.S. Chandrasekhar, your ACG governor from India region. I represent World Gastroenterology Organization as a member scientific committee and represent the Tamil Nadu Dr. MGR Medical University as the honorary professor and from my own institution, Medindia Hospital and Academy. And it's a great pleasure to invite the first two series of webinars on gastroenterology attracted over 9,000 delegates from all over the world. That really inspired us to move on to the third series with the world leaders in gastroenterology. And we have now the third series on gastroenterology with a tagline, name the topic, the world experts are here. With a new motto, the new EndoGeo webinar series is created a great news in this. And it has been endorsed by American College of Gastroenterology, accredited by Tamil Nadu Medical Council, and our academy partner being the Microlab Academy from Microlab, and is an initiative of Medindia Hospitals and Medindia Academy. Okay. The first series on this, the third series, the first webinar was inaugurated by Professor Dr. Jonathan Lighton, who is the president of American College of Gastroenterology. And we have scheduled 12 webinars from April 24 to March 25. And one of the flagship program of ours was held in September, where none other than the Nobel Prize winner, Nobel laureate, Professor Dr. Barry Marshall came as the faculty. He talked on the discovery, the journey of discovery of Helicobacter pylori and further being the discoverer of Helicobacter pylori. It was very well attended from delegates from all over the world. And these webinars would not have been possible without the help of my colleagues, Dr. Gokul Satya, Raja Yogesh, Dr. Prasad, and Dr. Tringana Sambandam. And what we designed this webinar, which has really become popular and very active and well attended, because we have ambassadors from all over the country, from India, from Dr. Chaubal, Pravir Roy, Ramesh, and Srinivas Rao, Praveen Kumar, Aravind Gopi, Grace, and Mahapatra, and so on, represent Nirmaljeet. So each one representing from one state of India. And usually we have international ambassadors from USA, and Malaysia, Nepal, Bangladesh, Nigeria, UAE, Australia, Nigeria, and Sri Lanka, Nepal. And recently we added one more ambassador from Myanmar, Dr. Tantain Se Ai, and we added that. These 12 webinars we scheduled with a varying topic from celiac disease, non-celiac gluten, and the journey of discovery of Helicobacter pylori, Barrett's esophagus, and the hepatology topics, and the other important. Now we have the colonoscopy and ERCP now, and next in January will be fecal microbiota transplant, and the probiotics, high quality colonoscopy, and high quality upper GI endoscopy, H. pylori, and so on. And we got accredited by our program by the Tamil Nadu Medical Council with 1 credit hours. That very important. This would have not have been possible without the partnership from the academic grant from the academy partner Microlabs Limited. Today's topic is going to be very, very interesting, and this is going to be on colonoscopy and ERCP. 2 important procedures every day gastroenterologists perform, and what is new in that, what has not been really covered, or what is that unmet need. These are going to be the topic here. And it is my pleasant duty to introduce the faculty. Professor Douglas Rex is a distinguished professor emeritus and director of endoscopy, Indiana University School of Medicine, USA. I know him personally, and he is well known for his prolific publishing in colonoscopy and colorectal cancer. And because of his publication and original work, He has been considered one of the authorities on colonoscopy in the world. He has authored over 200 original research papers, 55 book chapters, and 40 editorials, and 40 guidelines papers. He has been the past president of both the American Society of GI Endoscopy and American College of Gastroenterology. And the most important, the topmost award from American Society of GI Endoscopy is Rudolph V. Schindler Award, and he is the recipient of that. And he has been considered as I said, is a world authority. He is going to be discussing about what is colonoscopy unseen and to be seen. And this is going to be moderated by my friend, Dr. Sandeep Nijaman. He is a professor and HOD in Mahatma Gandhi Medical College, Jaipur. Earlier, he was holding the Department of Gastroenterology, SMS Medical College, Jaipur. He was the past president of Indian Society of Gastroenterology and Society of Gastroenterology Endoscopy of India. He also had a very good number of publications. Next is the topic is going to be discussed by Professor Dr. Nageshwar Reddy. He is the founder chairman of AIG Hospital, a very well-known popular hospital, and maybe the maximum number of cases being done there and the procedures in Hyderabad. He is the past president of World Endoscopy Organization. He is also the recipient of Rudolph V. Schindler Award, and maybe the first Indian or maybe Indian to get this award. And he's a Master Endoscopy Award. He's the recipient from the American Society of GI Endoscopy, and he is the honorary life member of ASGE for lifetime achievement in GI endoscopy, and publications over than 1,000 with a great H index also. We welcome you, Nagi and Professor Rex. And this is going to be done by another eminent ERCP specialist, who is Professor Dr. Randir Sood. He is the Chairman HOD Department of Gastroenterology, Medanta Hospital, New Delhi. He is the teaching faculty and examiner for the DPNB examination, National Board of Examination in India. He is a member of WGO Publications Committee. He has also been the past president of Society of GI Endoscopy of India. He is also having a very great number of publications, and I welcome the panelists too. Professor Dr. Surinder Raina. He is also a very eminent authority in the pancreatic endoscopy and pancreatology, and he is a professor of Department of Gastroenterology, the prestigious PGM at Chandigarh Postgraduate Institute, and other my colleagues, Dr. Rajesh Puri, he is the Vice Chairman, Institute of Gastrosciences, Medanta Hospital, New Delhi, and we have Ukali. His platform is shared by my colleagues from Chennai. Dr. R. Ravi is the Group Director, Medical Gastroenterology, Interventional Endoscopy, and Rela Hospital, Chennai. And my colleague, Dr. B.J. Kokul, is the Medical Director and Consultant Gastroenterologist, Department of Gastroenterology from our Institute, Medindia Hospital, Chennai. With this introduction, now I invite Professor Sandeep Nijaman to introduce the topic and invite the first speaker, Professor Douglas Rex. The program is like that. At the end of his lecture, since he has to leave by 8 o'clock Indian Standard Time, we'll take the questions related to colonoscopy, and we'll have later questions also with Professor Douglas Rex to know more about him apart from colonoscopy. Now I invite Professor Sandeep Nijaman.
Yeah, thank you, Dr. TSC, for giving me the opportunity to be part of this important lecture series. As you all know, colonoscopy is one of the most difficult endoscopic procedures to be done by an endoscopy. It requires quite a bit of skill, and there are always chances of failure, even in the expert hands, to have a full-length colonoscopy and ileal intubation. And it also requires an ideal preparation before actually, conducting the procedure. It's not like keeping the patient fasting and doing an upper GI. And there has to be a proper selection, because one has to have a particular indication to be kept in mind so as to start this procedure. And these procedures actually of colonoscopy last very long. Their number of procedures are very many, so proper ergonomics are also to be kept in mind, just as to be more friendly to the endoscopist. And there are difficulties encountered during colonoscopy, especially, rectosigmoid area, splenic flexure area, and ileocecal area for the ileal intubation. And adequate withdrawal time, which is nowadays very important, which will be discussed in detail, to not to miss the smaller lesions encountered during the colonoscopy. And one should also know that when not to do colonoscopy and when to stop when the procedure is not getting completed. And a proper actually checklist should be done for starting the colonoscopy so as to not to waste time during the procedure. And early recognition of complications, because you're doing a procedure which is actually requires a skill. So there are complications which can be encountered rarely, like perforation, bleeding, and it has to be the early recognition and a proper treatment is required. But for all this, actually, you have to have an expert in the field. We have a doyen in the field, Dr. Douglas Rex from US. He has the maximum experience of colonoscopy globally. So I'll invite him for his lecture and enlighten us what all we should know about colonoscopy. Dr. Douglas, you are on.
Hi, everybody. Can you see me and hear me okay?
Yes, yes.
Yes.
Yes. And you can see the slides also, I hope?
Yes,
Yeah,
yes,
very
yes.
good.
Good. Okay. Well, good evening, everyone. And thank you, TSC and Sandeep, for your kind introduction. It's early morning here in the US, and I've done a few colonoscopies already. And I'm delighted to take a break and talk with you a bit about colonoscopy. I won't be able to stay for my friend Nagi Reddy's talk, but you won't be missing me because I don't do ERCP at all. So I'll have nothing to add to the discussion, and I'll leave you to his good hands after we take some questions. I sort of interpreted the title as that I should talk about detection during colonoscopy. And I'm very aware that colonoscopy has cultural differences, and certainly between India and the US, there are differences in the prevalence of disease. And so we may emphasize different areas. And I'll try to get through some issues about detection relatively quickly so we've got some time to take some questions. So many of you are probably aware that in the United States, there is a task force that is made of members from the ACG and the ASGE that creates our quality indicators. And these were recently updated in both journals just a couple of months ago. And I'm going to summarize some of the key updates. In the quality indicators, there are a set of indicators that are considered to be what are called priority indicators. These are things that we hope all endoscopists will measure. And the adenoma detection rate, which has been the prime measure of the quality of inspection during colonoscopy, has had some modifications to the definition. First, the age to measure screening has been lowered to age 45 and older. This is consistent with our current screening guidelines. And it's no longer just for screening. It's actually going back to the original definition, which includes surveillance and diagnostic examinations, but not exams for other positive screening tests. So particularly when the adenoma detection rate is measured in patients who have positive FIT or positive Cologuard, which is, I know, used really only in the United States, but I'm sure FIT is used to some extent in India, then the adenoma detection rate should be about 15% higher. The threshold for acceptable performance has been increased to 35% or higher. So the interpretation of that is that if the adenoma detection rate is below that, then the doctor should really undergo remedial work to improve their ADR, but we would like for the ADR to go substantially above that. And we think in this new population, we should be able to get up to 55 to 60% with very high levels of detection. Then the minimum average withdrawal time in normal colons has been lengthened to 8 minutes. We have seen lots of evidence that actually to perform a careful examination requires more than 6 minutes. The previous recommendation, on average, it requires 8 to 9 minutes. We've now seen 3 large studies that have described groups of endoscopists. It's usually about 15% of endoscopists who have adequate detection of conventional adenomas, but their detection of sessile serrated lesions is low. And this results in a higher rate of post-colonoscopy cancer. So we felt it was time to introduce a separate detection rate for sessile serrated lesions. The rate of using recommended screening and surveillance intervals, this remains a priority indicator. And we actually see more failure to comply with the recommendations for this priority indicator than any other, but the recommendation is to reach 90% or higher. Bowel preparation adequacy has now been introduced as a priority indicator, and it should be 90% or higher. And the cecal intubation rate is now recommended to be 95% or higher. So what is a high quality colonoscopy? Well, it's got several components: excellent, well-tolerated bowel cleansing, safe and complete cecal insertion, very high detection, complete and safe resection, and then using cost-effective follow-up intervals. And I'm going to focus on very high detection, but I'm going to speak for a minute about bowel cleansing, because bowel cleansing, of course, is related to high levels of detection. So these are some tips for getting very effective and well-tolerated preps. And first of all, we are now focusing in the US on trying to focus on low volume preps, that is 2 liters or less, especially for routine outpatient colonoscopies. Excuse me just a second. So we judge bowel preparations in 3 ways, and these are by tolerability, efficacy, and safety. And we really accept that bowel preparations are not going to have specific organ toxicity. So with regard to safety, for example, we don't use sodium phosphate preps anymore in the United States because of the risk of kidney disease. Efficacy is, of course, prime, but because the 2-liter preps and the 4-liter preps have proven, 2 liters and less have proven to be better tolerated, this is the basis for emphasizing that we go to lower volume preps, because of this, of course, is the thing that patients complain about the most. We want to give written and oral instructions, and we try to emphasize now that there are visuals in these instructions. So these explain the importance of the bowel prep to effective examination, and the patient needs to understand what the effluent should look like, basically that it should be yellow before they're fully prepped, and they should contact us if they haven't reached that point. And then usually for part of the day beforehand, we recommend clear liquids. There's a lot of evidence from investigator-initiated trials that patients can use a low residue diet for part of the day before, but usually part of it is clear liquids. We want patients to understand what those are. We like systematically to identify high-risk patients for inadequate preparations. And this is a very nice review from my own group. It's a meta-analysis just published in the Red Journal that breaks down these risk factors into clinical factors and then socio-demographic factors. The clinical factors predict the prep will be inadequate. The socio-demographic factors predict the patient is less likely to follow the instructions for the prep. So for the clinical factors, we would increase the prep dose. This might mean that the patient would take some stimulant laxatives for 1 or a few days before they actually take the regular preparation to sort of debulk the stool from the colon. And the socioeconomic factors, these are addressed by processes like language-specific instruction and navigation. Finally, or next, we evaluate the effluent on the day of the procedure. And a general rule is that if the patient is passing brown stool, there's about a 50% risk of an inadequate prep. Under those circumstances, we would like to keep the patient in the endoscopy unit and salvage the procedure on the same day. So we'll give the patient additional prep in the endoscopy unit until their effluent is clear, and then we would still wait a couple of hours so that we can sedate them. Sedation is most commonly used in the US. And then to evaluate the prep, we would use the Boston scale, and the value of the Boston scale is that it is applied after you have done your intraprocedural cleansing. So just based on the prep alone, we typically, before intraprocedural cleansing, would see that about 90% of patients have had an adequate prep. We have to do some work during the examination to improve the prep, and we can get that adequate rate of preparation up to 95% and higher. And after that intraprocedural cleansing is when we apply the Boston Bowel Prep score, and we want to get a score of at least 2 or 3 in each of the 3 segments of the colon. And then next, as a quality indicator, measure the rates of inadequate prep. And there's going to be a new document coming out from the U.S. Multi-Society Task Force, and that document, as well as the ACG, ASGE Quality Task Force, now recommend that that should be at least 90%. This 90% recommendation was actually first made by the ESGE. The previous recommendation from the MSTF had been 85%, so it's been increased to 90%. If the preparation is inadequate, we recommend in our guidelines that the procedure be repeated within a year. And if you're doing that more than 10% of the time, then there's some sort of a systems failure. And so it's important in the endoscopy unit to review the systems once or twice a year and make sure that you're updated with the best practices and that you're solving problems that you're encountering. So let's talk specifically about detection. So I think detection starts with the knowledge of the endoscopist. And what we have to understand is that both for the conventional adenomas and for the serrated class, and particularly for the serrated class, that there's a segment of lesions that are extremely subtle. So on the left, you can see a very flat conventional adenoma that's better seen there in narrowband imaging, and on the right, a very flat sessile serrated lesion. And so the endoscopist must be well educated about this spectrum of disease that's extremely subtle and constantly looking for it by evaluating color changes, texture changes in the mucosa, and areas where the underlying blood vessel pattern is disrupted. Now, I want to point out that the new artificial intelligence programs are not doing well with the detection of large flat lesions. And here on the left, you can see a sessile serrated lesion. Another one on the right, you can see that there's an AI program activated, and in neither case is it generating any signal. So we have something special with the AI programs in that they're trained on a specific set of lesions. And I think probably these programs have not yet been well trained on the most important lesions that contribute to post-colonoscopy cancer, which are large, very flat lesions. So keep that in mind if you're using an AI program. So what does it take to achieve high levels of detection? Well, we can do this if we come to the procedure with our basic understanding of how to find and what these subtle lesions look like, and then we apply the basics. And the basics are a high definition scope. I think that using standard definition scopes now is no longer acceptable. Meticulous technique, and as I said, it takes a minimum of 8 to 9 minutes to apply that effective technique. Split or same day preparation, and then reporting of ADR. There's good evidence that when we report ADR and give feedback, many doctors start to improve their performance. The basics of technique really have not changed over the years. They are to look behind all of the folds, to clean up, and to achieve adequate distension. In the right colon and the rectum, we generally advise people to examine twice, because double examination is another effective way to reduce missed lesions. And the right colon and the rectum are the two segments of the colon where post-colonoscopy cancers most often occur. So the basics of good examination are to take the time to stick the tip of the scope, the camera, between every set of haustral folds. As we pass haustral folds, we cannot accept, if they are shadowing mucosa, to just move on. We have to go back in and stick the tip of the scope between every set, every pair of haustral folds, and do our best to expose that mucosa. In the right colon, we examine from the appendiceal orifice back to the hepatic flexure, then go back to the cecum. look at the cecum again in the forward view, and then examine the right colon a second time, either in retroflexion or in the forward view a second time. They're both equally good. I prefer usually to do the second examination in retroflexion. In the left colon, if the patient's in the left lateral decubitus position, the main problem is often achieving adequate distension. And I'm often very alarmed to see that doctors will accept that the left colon is not fully distended and just move on. It's good, I think, to use a very aggressive in and out approach so that although you're not doing a formal double examination, you're going back and forth across each set of haustral folds. To achieve distension, using CO2 is valuable because you don't have to worry about post-procedural pain from gas distension. You can fill the left colon with water and get a good examination. And what we do sometimes is we literally will grab the patient's buttocks and squeeze them together. We call that the butt squeeze or cricoid pressure. And it sounds kind of silly, but it's very effective because when you're not distending, the problem is usually that gas is escaping from the patient's anus. And if you just put some pressure on that, you can immediately achieve a nice distended left colon. So those are the basics, and those have not changed. But people are very interested in whether we should employ additional technology. And I will tell you that I like in every examination to employ a technology to expose more mucosa, something on the end of the scope. I usually use the endocuff vision, but if not that, then a short distal attachment, a clear distal attachment, and a highlighting tool. And I usually use a couple of highlighting tools, one electronic chromoendoscopy and the other artificial intelligence chromoendoscopy, which I still use in inflammatory bowel disease, can be used in, of course, regular colonoscopy, but most of us, including myself, don't do that in the US. So here is the endocuff vision. It's improved the adenoma detection rate in multiple randomized controlled trials. In meta-analyses, the improvement is usually about 7%. And the other thing that we've shown in a randomized trial is that you can actually examine the colon faster with this device on the end of the scope. You can shorten your withdrawal time by an average of about 2 minutes and not have any reduction in detection. In fact, detection is numerically better still, even though you're doing withdrawal faster. So I think you just reach the point when you're looking between folds that you're satisfied more quickly when you have a device on the end of the scope that you've really exposed all of the mucosa between a pair of haustral folds. And then chromoendoscopy, I think, is really potentially going to make a comeback. And both Fuji and Olympus have electronic chromoendoscopy platforms now that are comfortable to use. Narrowband imaging with the 190 series or the Xera 3 series has been actually very effective for detection. But people don't like narrowband. We're in narrowband over here on the right now because it's uncomfortable. If there's mucus present, the mucus looks pink, the image is dark. But with linked color imaging from Fuji or texture and color enhancement from Olympus with the new Olympus scopes, here you can see the TXI format with Olympus. We have better detection and they're very comfortable. Endoscopists don't mind being in these to examine the colon in the same way that you do with narrowband imaging. So I think electronic chromoendoscopy could make a very nice comeback. Good data for both of these platforms that they increase adenoma detection, and for LCI that it also increases serrated detection. And then, of course, the artificial intelligence program. And I just mentioned my concern about this is I don't think these programs are well enough trained for the detection of large flat lesions. They're very good for small flat lesions, but I think we have to really pay close attention for these larger lesions when we're using an AI program. So what's a high quality colonoscopy? Again, we focused here primarily on high detection and added in a few comments about bowel cleansing, which are related to that. So thank you so much for your attention. I just tried to give an overview, and I'll look forward to your questions.
Thank you, Professor Rex, for your wonderful, at the same time, very enlightening talk. And we have several questions. We'll start with Dr. Sandeep Nijavan, who is the moderator. You have 4 or 5 questions. Maybe we'll start like that. First moderator, second moderator, then the panelists, then we'll come in a round. The last 5 minutes, leave it to me to just ask something in different type of questions. Okay?
Yeah,
We'll start
yeah.
with Dr. Sandeep Nijavan.
Yeah, Dr. X, do you use any anti-foam agents? Because at times, foam does actually, small adenomas could not be seen because of foam.
Yes, no, thanks, Sandeep. I think that's an important question because we have multiple randomized controlled trials with simethicone. And I think overall, and the meta-analyses show that simethicone does increase the detection of adenomas. So we put it primarily in the bowel prep. And I think a key thing is if you add simethicone to the bowel prep, that you put enough in there. And you want to, it's okay to have some with the second dose, but you particularly want to have simethicone in the first dose, but you particularly want to have it in the second dose. And probably, something in the range of 700 to 800 milligrams of simethicone is needed to give the best result. Now, during the procedure, of course, we use simethicone too, because, it doesn't, we still have bubbles. And I think we should try to wash all these bubbles down and really have a clean surface. And of course, some people follow the admonition from the companies that we not put it in the water jet for fear that it will clog up the scope. So then you have to have, some solution that you can flush down the scope to get rid of bubbles. But I think it's a very important and useful thing that we shouldn't overlook.
Do you routinely use or in selected cases use anti-foaming agent?
We use it in our bowel preparation for all cases, and then during the procedure, we would use it whenever we need it.
No, about anti-foaming, whenever needed, not routinely. No?
Yeah, and I may not be understanding you, TSC, but from an anti-foaming, I assume you're talking about simethicone. Is that right?
Yeah.
Okay. We use it in the bowel prep in every single patient, but we don't necessarily use it during colonoscopy. We use it when we need it.
Okay. The question from my side is, we always talk about alpha loop and reverse alpha loop and gamma loop. Have you come across any time gamma loop and you have to really make it very difficult to do colonoscopy and undo that and go ahead?
Okay, this is an interesting question that perhaps that we can talk about. I find the whole discussion of loops to be interesting, but I personally do not teach or talk about the different types of loop, the alpha loop, the N loop, the gamma loop, etc. Because in our practices in the US, we are not using the scope guide or the magnetic electronic imager at all. I use it sometimes for teaching, but for the most part, we don't really know for sure what kind of loop that we have. So I do think loop formation and avoiding loop formation and reducing loop formation is the key to great colonoscopy. But what we teach is, first of all, recognizing loop formation by, how much scope is in the patient and whether or not there's good one-to-one transmission, and then very prompt reduction of loop formation. Now, I will say that how to reduce loops. I mean, I feel, because I've done a fair amount of live endoscopy where I have the magnetic electronic imager being used. And although I can't always say exactly what kind of loop, I can personally always say whether there's a loop. And I can tell by the direction of unwinding clockwise or counterclockwise and how it feels, which direction to go in order to achieve unwinding. But so I think we rely in the US primarily on feel. We don't use the imager and we don't use fluoroscopy, and we seem to have extremely high cecal intubation rates. So beyond that, I can't really comment on specific loops because it's not the way I think about loops or how I manage them during colonoscopy.
Yeah, Dr. Dutt, there's one more question that what are the tips to do retroflexion in cecum? Because normally in colonoscopy, we are not doing it routinely, but what is the advantage of, and what are the tips? Even in rectum also, what are the tips?
Sure. So in the rectum, I use a slightly different maneuver than I do in the right colon. So in the rectum, the first thing I do is to come back all the way to the dentate line and assess the rectal space. And occasionally, there'll be somebody who has had, for example, ulcerative colitis or radiation to the rectum, and they have a narrow rectum, and I think the maneuver should not be performed. That's a small percentage of patients, but I think best always to examine in the forward view to the dentate line and assess the space. I then usually have few things in mind for retroflexion in the rectum. I usually pick the wall that's kind of most en face to me. That is, I'm looking straight at it as opposed to tangentially. And I pick a spot a few centimeters above the dentate line, put the scope tip there, and then push the scope in and go max up. And it's a very simple maneuver. I don't usually go both max up and max right or left until I'm actually in retroflexion. And then I may swing to the right or left to see the findings around the anal verge better. I think the key thing for safety in rectal retroflexion is to keep the scope in the lower rectum. Occasionally, people allow the scope to slip up toward the rectosigmoid, and this is where perforations have occurred. And you see mention in the literature of people having perforations during retroflexion, and I think that's primarily from letting the scope slip up toward the rectosigmoid and not keeping it in the lower rectum. Now in the right colon, it's a little bit different approach. So the first thing is to go down. I'm going to stand up for a minute so people can see my arm here. But I would go down into the cecum and usually along the medial wall under the ileocecal valve, go max up. And then I usually will push the scope in a little bit so that there's some bowing along the right wall, the lateral wall of the right colon. And that will tend to tip, if this is the tip of the scope, that will tend to tip the scope more toward the lumen. And you may, at that point, slip past or under the ileocecal valve and see the lumen. If not at that point, I would rotate max left and then usually turn the scope over in a counterclockwise direction. And that typically will achieve retroflexion. There are some times when right colon retroflexion is difficult. For example, if you're in, usually in the right colon, if we first do a forward examination, we can see if the right colon is straight. If you're sitting in the mid-right colon and you cannot see the ileocecal valve, then the cecum is often flipped back medially. And this will make the retroflexion maneuver more difficult. And so you need to be aware of that individual anatomy, usually a cecum that's flipped back, or if the right colon happens in an individual to be narrow, it can be a bit more difficult. And the maneuver should never be forced, but actually it's proven to be a very, very safe maneuver. I think it's a very important maneuver to master for therapeutics because there's a group of lesions in the right colon, especially on the medial wall of the, would be the distal ascending colon near the hepatic flexure, where much of the lesion is only seen well in retroflexion. And you need, from a full therapeutic capability, to be able to retroflex in the right colon. Also, I think in the transverse colon occasionally, but more often it's for lesions around the hepatic flexure. Now, I will say that I think using a standard colonoscope or a pediatric colonoscope and retroflexing in the descending colon or sigmoid colon is potentially dangerous. And this is where people have had perforations, not so much in getting into retroflexion, but getting out of retroflexion, because the scope can get sort of bound into a narrow space. And just in general, even when you're in the right colon, when you're unwinding from retroflexion, you want to release the controls and pull down on the insertion tube so that the bending section, rather than just flipping straight up, you're pulling down so that you're putting less pressure on the wall. But if you have a very difficult lesion in the sigmoid or the descending, where to access that lesion, because it's on the other side of a fold, you need retroflexion, I would use an upper scope. And you should even check that upper scope before you go in and make sure that it has very good deflection capabilities. Something I teach my fellows to remember is that what the scope does in the patient, if you practice on the table to see what it does or to understand what it does those same things in the patient. And when you go into maximum up deflection with a colonoscope, you're at 180 degrees of up deflection. Same thing with down. When you then go max right or left, the instrument does not turn to the right or left. It hairpins in the up direction. And this is very important for going around turns, for achieving retroflexion. If you understand what it does on the tabletop, it'll do the same thing in the patient. But right-left behaves very differently. The scope does different things when you turn right-left if you're already maxed up compared to when the scope is straight. And that's critical for every endoscopist to understand.
I think you
Thank
made.
you very much for the tips.
Sanjay, you agree with me that you made an explanation like what we get in live workshop. Thank you.
Yeah,
And
no.
you were discussing so much difficulty, Dr. Rex. When do you recall the case where you found it so difficult? Okay, this is the time to give up the colonoscopy procedure. So what is the golden rule that, okay, enough is enough, this is not my day, we'll give up, otherwise they end up in complication. So
When to stop?
When to stop?
Yes. Yeah, well, that's a fair question. I think, myself, because I have a very large referral practice for patients that have had a previous incomplete colonoscopy. So, and we've published about the tricks and the tools that we use. I think when you have exhausted all of the maneuvers that you would use to overcome either a very bad, in the U.S., because we have a lot of diverticular disease. I'm not sure what our relative prevalence of diverticular disease, but one of the problems we have is a bad sigmoid, very angulated and narrowed. So that's a different set of problems than the very long redundant colon. And I think what you do is you go through a standard set of maneuvers, and if you've tried all of them, then you should quit. It doesn't pay to keep doing the same thing over and over again if it's not working. So when you feel like you've tried everything that you should reasonably try, that's the point where you should stop.
I think we have given some instructions to the postgraduates here. When you do the rectal examination, you start feeling inadequate preparation when the finger stall itself. Better inadequate preparation, as you said, high risk factor, better to withdraw. That's the same thing.
Yes,
And the diverticular disease is a very difficult thing to proceed beyond certain thing. I think that is a very good point to be taken into. Dr. Ravi, you have a question on colonoscopy to Dr. Rex?
Unmute yourself. Yeah.
Yeah. Unmute yourself. While he's unmuting, can we have Dr. Gokul to ask question and then followed by Ravi?
Yes.
Gokul, you are through. Now I'll ask Ravi while you are getting ready. Okay?
Yeah. Dr. Rex, I enjoyed the talk very much. My question is that we always talk about 6 to 8 minutes withdrawal time. It's always more than 8 minutes, I think. If somebody has a time to do a withdrawal time of 30 minutes, I think they should take 30 minutes to withdraw. And is AI reduce the withdrawal time anyway?
So yeah, this is a good question. I think part of the question, Ravi, is, or what we're asking is, at a certain withdrawal time, does the benefit start to level off? And I think it probably does. If you look across the data on adenoma detection and cancer protection, what you see is that a lot of it sort of peaks out at around 9 minutes. And for some endoscopists, that may extend out to about 12 minutes. And of course, this is withdrawal time without, biopsies or polypectomy. And so if we start talking about times of, 25 or 30 minutes, the incremental benefit is decreasing. And of course, at that point, we're also, if we have a sedated patient, we're increasing the risks associated with sedation. And if we have an unsedated patient, we're probably increasing the amount of discomfort and, sort of reducing the quality of the experience. So I think that some people will tend to have very, very long times because their personality and their tendency is to be so careful on behalf of their patients. But there is probably a limit, and people should be reasonable about it. And if you're measuring, if you have very good, detection levels, ADR, and your withdrawal time is super long, 20 or 25 or 30 minutes, I think you could think about whether you could lower that and improve your efficiency, probably a little bit of a safety benefit for patients also. I think that's a fair answer.
Okay, thank you. Dr. Gokul?
Yes, sir. Thank you, Professor Rex, for the fantastic lecture. I have a question. We know that the prevalence of adenoma increases with age. The newer metrics says that the age has been reduced to 45, and the ADR has actually been increased to 35%. So is that going to create stress among the colonoscopists? What is your thoughts on this?
So right now, the evidence in the US is that the 45 to 49-year-old population has a prevalence of adenomas and advanced adenomas that is just a little bit lower than the 50 to 54-year age group. And what we're seeing so far is that group is usually not more than about 10% of the colonoscopies that groups are doing. So we don't think that that's going to have a big impact on the ADR. There are a couple reasons why the threshold was raised. One is that we added in the surveillance and diagnostic patients. And if you look across the literature, the ADR is highest in surveillance patients, screening is in the middle, and diagnostic is lowest. I've always been fascinated by that. I'm not sure why diagnostic is lower, but I think it probably in the US has to do with people presenting with symptoms have often been scoped previously, and now they're getting scoped again because they've developed symptoms, but we don't know for sure. But we raised the threshold because of adding in the surveillance patients, really. They average about 7 to 12% higher, and we think that 45 to 49-year-old group is not gonna lower it very much. And we just generally are seeing more evidence that kind of the higher you go, it seems to have some additive protection. In the screening population, that seemed to clearly be true up to around 45%. So there were a lot of moving parts in deciding what to do, but we wanted to reconcile the age to start with the screening age in the US, and at the same time try to keep everybody incentivized to perform better by raising the threshold.
We have Professor Tantan I from Myanmar. You have a question to Dr. Rex. You unmute yourself and ask a question. Unmute. You are unmuted then. Okay, while she is unmuting, we have Dr. Rajesh Pri. I know you are a US man. You have anything to ask about colonoscopy related thing?
Yeah, thanks, Professor, for the nice lecture. I've got 4 questions. Question number 1, just wanted to know how to retroflux. You have told, but I request if the time permit, you again tell. Otherwise, if you can send some demo to Dr. Chandrasekhar, because that is the one problem which I encountered. that we can discuss later because you have already answered. I have some question. Inflammatory bowel disease. The two important things, the disease should be in the quiescent phase and patient should have a good bowel preparation. Beside that, there is any other trick or any other method you want to give while doing the colonoscopy in inflammatory bowel disease patient?
Well, I mean, I fully acknowledge that it's a challenge in inflammatory bowel disease that is distinct from the non-IBD population, and especially I think the more scarring and distortion of the wall there is, potentially the more difficulty there is. I do think that if we look at the literature suggests we should be doing high definition colonoscopy. As you know, there's literature both supporting chromoendoscopy and electronic chromoendoscopy, and there's been a bit of, I think there's continuing to be controversy about it. I actually still use chromoendoscopy, and I think that chromoendoscopy does add, to detection, and I'm very comfortable with it, and I don't feel that it adds to my procedures because I'm not generally, unless the patient's at very high risk, for example, in PSC or a previous history, we've cleared out significant lesions. I'm not doing non-targeted biopsies. I'm pretty much only doing targeted biopsies. And so I personally prefer chromoendoscopy, but I realize that the issue is not settled. I think that neoplasia, it's, that we all encountered cases with IBD where you simply can't tell whether the changes are inflammatory or potentially neoplastic. And in those cases, we have to resolve them by biopsy. And I don't have too much else to say. I wish I had a magic fix for it. I think very, very careful study and detailed study of the colon with chromoendoscopy, and sometimes the dysplastic lesions, it's very clear that we're dealing with a dysplastic lesion. Other times we're not sure, and then we have to resort to biopsy.
Okay, Rajesh, when you are ready with the other question, we have Dr. Professor Tantanai from Myanmar is. Please ask very brief question and brief answer. We have 12 more questions to cover in 7 minutes. So I will give a chance to everyone so that, okay, yes.
Do you hear me?
Yeah. I'm hearing.
Yes, okay.
And Professor Rex also hearing, please.
Do you use Buscopan during the procedure? Buscopan.
I don't use Buscopan during the procedure because the IV formulation is not very available in the United States. That's the only reason that I typically don't use it. The only agent that we really have is glucagon, and I don't use that very much either, nearly as much as in the upper GI tract, because the colon is not as responsive to it as the small bowel.
Yes. Okay. Do you switch on MBI when you withdraw at the right-sided colon?
I don't usually, but I will say that here's my personal preference. I think MBI is particularly good for serrated lesions. And so if the prep is excellent, I often will use MBI in our serrated polyposis patients, of which we have many. We have over 500 in my practice. But I like for the prep to be really good before I use MBI. So I would primarily, with the limboscopes now, I tend to use TXI. And if I have Fuji-scopes, which I sometimes do, I really like LCI.
Okay.
Thank you.
Dr. Nagi, you started using AA now. So what is your take on AA and colonoscopy? Professor Rex has already covered. You advises, both of you, I just want to know, you advise AA in all cases of colonoscopy procedure, we have the inbuilt AA, whatever equipment you have, or you select it. What is your take, Nagi and Professor Rex? And
yeah, my view is a little different. My view is that, first of all, polyps are not a major problem. Screening colonoscopy is a major problem in our country. So I don't think we'll invest too much money into trying to detect polyps in artificial intelligence way, where we should try and do it in a normal intelligent way. The reason, of course, is that studies have shown that AI detects polyps which are very small. I don't know if Doug agrees with me.
they're less than 10 millimeters in size, and these don't have any clinical consequences. So trying to put these costly AI systems into our endoscopy areas, trying to detect very small polyps which are no consequence, for me, I think that's not an important area. I would use more AI into scheduling, post-scheduling, patient education and so on, and not computer vision as it's used in the West. So for me, I think the AI that is practiced currently may not be of much value in our country.
What do your take, Professor Rex? You use in selected cases AI, or AI really complement the human eye or the recognition of the polyp? Where do you go about?
Yeah, I mostly agree with Nagi. I'm not sure that it's worth the investment. As I said during my talk, and I showed some examples where it's not detecting large flat lesions. Now, it may be able to, but first these algorithms need to be trained on large flat lesions. And those are the most important ones to detect. So I will say that using it on a regular basis, a lot of people become I think because there are a lot of false positives, tend to not pay a lot of attention to it. We notice we have it available and we study it, but we notice our doctors not remembering to turn it on. And I think oftentimes they sort of ignore it because the false positives are still averaging about 25 or 30 per case. And so I wouldn't, especially if I had limited resources, I don't know that I would make that investment at this time.
Okay, and we have two quick questions before I will move on to the lighter section. And since you have to leave by 8 p.m., do you have any questions from Dr. Randir, who is there, and Dr. Farooq from Bangladesh? Dr. Randir and the Farooq.
Thanks, Dr. Doug. It was a wonderful lecture and very illustrative also, because you explained the procedure very well. Well, I don't think I have any specific question. You answered the AI, incorporation in the algorithm of colonoscopy, and we do use AI predominantly when fellows are doing the colonoscopy, because it does increase their ability to spot the lesions. Whether it leads to improved outcomes, we don't think it does. So the AI is being used routinely on withdrawal in our center, but it's because it comes incorporated in our system. But as outcomes, we have not really calculated when it really affects the outcomes of the patients.
Okay, thank you, Randir. Dr. Farooq, you have a question?
Thank you, sir. I really don't have any question, but one thing I can say is that we are still learning a lot from your deliberations, and we are really getting benefits from hearing this thing from you.
Okay, last 2-3 minutes, rapid fire to Dr. Rex, because you are not available in the chit-chat session. The first question, rapid fire, is how you are so passionate. How did you take up colonoscopy as your full career? So how did you, what motivated, or what is thing?
Well, my mentor was a guy named Glenn Lehman, and he told me that I was going to be studying colonoscopy. And I always did everything he said. So, but I will tell you that when I really got interested in colonoscopy in the 1980s, very little was actually known about it. Everybody kind of assumed that you went in, you saw what you saw and you took it out. And, everybody was interested in that time in H. pylori, and understandably so, because it was a very important issue. But I think that we kind of successfully turned it into a science, and now I think with people like Michael Burke, it's the whole process has been turned into a science, and that
was the need of the hour. That was the need of the hour, which took you to the colonoscopy. Huh? So, what is the recently the book you read apart from the medicine or the endoscopy? What is the book which you really read? Read recently? And
right now, I'm reading a book called Talking to Strangers, which is by Malcolm Gladwell, and it's about how we can actually try to tell whether people are being truthful. How we often so many of us get fooled by con men and so on. And so that's what I'm reading right now. But I mostly read nonfiction.
Okay, very good. Non-fiction, huh? You write non-fiction
Yeah.
or fiction.
Yes.
I think most of us are not strangers to you. What is the famous quotation really inspires you every day, or something you really would like to tell others? Famous quotation, the one.
Well, I spend most of my time telling the fellows to work the folds. So that's my. Look very carefully. Look very carefully during colonoscopy. But beyond that, TSC, I don't have a specific thing that I quote on a regular basis. My people over here probably would disagree with me and tell me that there is something I say all the time. But
okay, what is your hobby apart from the hobby you?
Well, right now my main hobby is pickleball. So I don't know if you're playing pickleball in India, but it's all the rage here in the U.S.
I thought now chess has become very popular now, and the Indian has become the world champion. So, and
pickleball is also coming up.
Yeah, which one?
Pickleball is also coming up in India.
Yeah, it's fun. Get a little exercise, more than chess.
Okay, what is the famous the sports personality whom you like it? Famous sports personality.
Most famous sports personality that I like. Well, gosh, I am kind of a sports fan. I think right now I really like Shohei Ohtani because he's really good at hitting and good at pitching, and we haven't had anybody like that since the famous Babe Ruth.
And a hypothetical question: what you would have become had you not been a doctor? Had you not become a doctor, what would have been?
I probably would have been a history professor. I very much like history, and if I retire, I might do that.
Oh, you like history so much? So I think one day you should talk about history of colonoscopy, how it evolved and the thing, no? So that
sounds good.
Nice. And you ever do the colonoscopy without sedation in your practice anytime?
Yes. We have patients who request it. They're often professionals, and so it's only about 2%, about 1 in every 50 patients, but we do unsedated colonoscopy, yes. Typically, I would go in underwater under those circumstances and talk to the patient, talk them through it, and we generally have a very high success rate for the patients that are motivated to do that.
I think we had a lovely time with you, Professor Rex, and it was a wonderful lecture, and you told us so many things about the guidelines and how we need to go it, when to use the most important is you have to do the right colon examination twice, and right colon you can do the J maneuver, what we do normally in the rectum also, and how to do that. I will expect some diagrams from you for Dr. Sandeep wanted this, and we enjoyed the deliberations and your sports personality, hobbies, and the kind of interaction we had. And do you is it true that some model when the colonoscopy actively was shown that it became a very popular procedure? And what is how you develop the popularity of the colonoscopy among the the public? How?
Oh yeah, I think that there were a lot of people that were involved in that, but I think colonoscopy sells itself really to the public because it's the only examination where we see the entire colon and where we can remove procedures. So I think colonoscopy is susceptible to disruption when the right, truly disruptive test comes along, but that hasn't happened yet. And so we're going to be doing colonoscopy, either screening or therapeutic, I think, for a long time.
I thank you very much on behalf of the directors of the Medindia Academy and American College of Gastroenterology. We're going a wonderful talk and we enjoyed it. And you will be missing you for Nagi's talk and that another very interesting talk. And Sandeep did a great job. And we welcome you to another series of webinar maybe next year. So we look forward to see the history of colonoscopy that time.
Thank you, TSC and Sandeep and everyone. Nagi, it's good to see you. I'm sorry I can't stay for your talk. All the best to everyone.
Thank you. Now, thank you. Now another very interesting talk, another eminent personality, I think easily he'll maybe the one of the, or maybe the one who had done maximum number of ERCP in the world. I think, I don't know whether how much he has done, he would have forgotten. And how safe he has done it, that's more important. And how much teaching he has really inculcated, and how many trainees he made it, that is also equally important. How he popularized the endoscopy workshop, starting from untiringly he has done it, so many people, and how many disciples he has produced. And I welcome you, Nagi. And I will hand over the mic to Dr. Randir Sood. He would introduce the topic and invite you. After that, after the talk, we'll have a panel discussion. Then you will also have a share of your the latest talks, also questions to you. Okay, right.
Thank you, TSC, for letting me speak. And
Thank you.
now I'm.
I gave a chance, Ranjit.
So, no, it's my pleasure to invite Nagi to deliver his talk on the ERCP, the met and unmet needs. Nagi, isn't it strange that an obstetrician had to do a first ERCP in 1968, McCune, getting into the wrong hole, which it was alien to the obstetrician, and perform an ERCP. And thereon, then, it has evolved into therapeutic aspect, and, the intense contribution of Peter Cotton in, standardizing it and having gained the initial experience. And, then with the evolution of devices, evolution of the scopes, we have been able to do more and more with the ERCP. And now with the EUS coming in, we have another device which can actually complement or compete with it. So how do you look at it today and in future?
Thank you, Ranjit. Thank you for the kind introduction and also introducing the topic. First of all, I'd like to thank TSC for this. All these webinars is doing, which are becoming extremely popular. You can see the number of people who have logged in today is extremely high. That shows the popularity and the concept is picking up. It's also both a pleasure and pain to be in the same league as with Doug Rex, because Doug is such a powerful speaker, and it's an honor to be on the same platform as he's been, but it's always very difficult to duplicate and try and imitate what he says. So my job also has been very interesting, because TSC told me I'm giving you a challenging topic. I said, what topic? And he said, the met and unmet needs of ERCP. So it took some time for me to think about it and come to a conclusion. And what I'm going to do is to give you my thoughts on this. I know there may be variations also with so many experts here, including Randir. What I'm doing, I'm going to share my slides. And can you see the slides now?
Not yet.
Just waiting to see them. Maybe sharing.
Yeah. So you have to give me the.
Monali, can
Now I think you're starting to see. You're seeing now?
not
yet,
yet,
Nagi.
Nagi.
So
Monali?
I think
Uh,
it's going actually. My slides are there. I don't know why.
no. You have to go to the window. There is a thing called
Yeah.
yeah. I think you're.
It's visible now.
Yeah. Now, yeah.
Now we got.
Yeah, where we got it.
Okay. So I'm going to start on this ERCP unmet needs. And before I actually go through, let me just give you an overview of what I'm going to do. I'm going to first give a brief for the next first 5 minutes, some very interesting background of the journey of ERCP, part of which Randir mentioned, and then go to actual met and unmet needs in various aspects. So you see, like Randir mentioned, McCune was actually a obstetrician and a surgical gastro also. Did the first ERCPs in 1968, but then after 53 cases he stopped because it took him 4 hours to cannulate the pancreatic duct. He was using an oblique view ERCP scope, which is not very good, and therefore took a long time. He was busy surgically, gave it up. ERCP was actually popularized by Itaru Oi, a young Japanese doctor who immediately after finishing house surgeon did a very clever thing. He married the daughter of an endoscopy manufacturer and got a special endoscope made for himself, a side wing endoscope, And consistently over 70% of the time, he could actually cannulate both the pancreatic and the bile duct, and was the first to show how ERCP can be done very easily. It was 1973 that Kawai and Klassen did the first endoscopic sphincterotomy to remove stones in the common bile duct. And this was, I think, a seminal event because this is the first major therapeutic endoscopic procedure. There's an interesting story behind this. They published both the papers in 73. And because I had an opportunity to talk to some of the pioneers in this, I'll just show you a little story. Kawai in Japan, who was supposed to be the first one, never did ERCPs in his life. He was a professor there, and in Japan, professors are given the first name. So his name is given. Actually, the person who did all the ERCP sphincterotomy in the world first time, Nakashima. In fact, he died 2 years back. I met him before his death, and he was very bitter that nobody recognized he's the one who did the actual ERCPs. In Germany, Klassen and Demling, when they did the first ERCP, actually locked the room. So nobody actually knew till now who actually did. And again, the Klassen, Meinhard Klassen, passed away recently. And before he did, I co-chaired one session with him and asked him, who actually did? Because if you see all the photographs in the literature, you'll find that Demling is holding the scope and Klassen is holding the mouth gag. But he told me actually it was reverse. He actually did the sphincterotomy and Demling was holding the mouth gag. So that was the real truth that happened. So this was how it was at that time. The seniors were given a lot of respect, unlike what happens now. And this was the first slide I borrowed from Meinhard Klassen, where he was having this slide of the first case he did CRCP. In fact, this was a nurse working in gastroenterology. She was the one who had to get ERCP because nobody else was agreeing. She was working in gastroenterology, had a CBD stone. They put her on the table and fortunately removed the stone. The first sphincterotomy in Japan was done on a medical student, again rotating in gastroenterology. Unfortunately, that time he developed a CBD stone, and you can see that an ERCP was done. But people are frightened to get ERCP done because 3% of those who had ERCP done for a stone were dying because of cholangitis. Did not have baskets, did not have balloons to remove the stone. Only a sphincterotomy done was left. So at that time, Dietmar Werps, who was a very famous German endoscopist, actually thought of a nasobiliary tube. And every patient with a sphincterotomy used to get a nasobiliary tube put in. And repeatedly, cholangiograms were being done, and when the stone slipped off, they were removing the nasobiliary tube. Of course, these are all the pioneers in 1970s who were responsible for developing ERCP, and this particular person, Claude Liggery, was the first in France in 74 to do a ERCP. He also died recently, but I was talking to him a few years back, and he told me that as soon as he did the first ERCP, the director of that particular hospital called him, government hospital, told him he's fired from the job. The reason was that he did a very dangerous procedure and all the surgeons were very angry with him. So this was the kind of opinion that was there even in 1970s for ERCP. Peter Cotton actually coined the term ERCP. In fact, his first paper in Lancet was a cannulation of papilla of water. Look at this paper. This paper, right now, if you try and publish this, even the local newspaper won't take it. That was the level at that point of time. The first biliary stenting was done by Nip Sohendra, and the best ERCPs in the world, in my opinion, ever was Keys Hubrisky. I went to watch him once doing ERCP. All the people in the unit would do the ERCP. Everybody would fail, and Keys would then take the scope, and 100% of the time was going into the bile duct. The secret was that he had a very few movements. He used to move the scope very less, and that seems to be the most important thing in ERCP, not to move your scope. Whatever small movements are actually going to the tip of the scope very easily. This is again a historic picture, 1978. Joe Geenan called all the endoscopists, United States, to come together for this conference, and only 4 people were actually doing sphincterotomies in US at that time. In this picture, you can watch Meinhard Klassen actually looking in the lecture scope as Geenan is doing this, and in fact, you can see none of them are actually having any gloves in their hand. At that time, no gloves were used, so infection rate probably. Till some time back, and this is what both TSC and Randhir would remember, we are making our own stents till 1990s. We never used to buy stents. We used to take this tubing from Wilson Cook or Don is to kindly supply this, have a hot water bottle in our ARCP area, and then make these stents quickly. This used to be a very common procedure. But all this has changed completely. ERCP has become science, a very important techniques have come in now. And what I'm going to do over the next few minutes is to discuss the various met and unmet needs in the different areas. Let me start first with the cannulation technique. Now, cannulation technique has matured. Most community endoscopists can go up to 90% success rates of selective cannulation. If you are a specialist endoscopist or in a specialist center, you are expected to do 95 to 99%. How do you achieve this? Because of advanced techniques that are available, like a pre-cut, double guide wire technique, Goff technique, and so on. So it's believed that using these techniques, you can reach this. But the point is, can 99% of everybody, even the non-expert, manage to actually get a success rate? I think we should achieve this if we have some techniques, and this is the major unmet need that we have in ERCP. The standard technique is to use these guide wires, especially I think angled hydrophilic guide wire. But I think we are going to expand further, and what is going to happen, as I see it, is that we are starting to get this cholangioscopy guide wire. That is a small CMOS tip can be put. Now, CMOS tips can come up to 3 millimeter. Very small ones can be put to the tip of the guide wire, and then these guide wires can then go through the papilla, because if you look at this, actually the guide wire is getting stuck into the papillary folds here and not going forward. That's the reason why we fail. This can be redirected with this. Similarly, we can have pH sensitive ERCP guide wires. Once it goes into the papilla, based upon the pH in the bile duct or the pancreatic duct, can selectively go into these ducts. These are engineering realities that can occur, and I'm sure in future this will come through. Another one is, of course, we use double guide wire technique very frequently. Now this can be done by available sphincterotome. This sphincterotome has two openings. So one opening, you pass a guide wire into the pancreatic duct. Through another opening, you can actually pass it into the bile duct. So double guide wire technique with a single sphincterotome. I think this actually is a video GIE video a few years back, and it's going to be reality. And further, I think artificial intelligence, like everywhere else, into go into use. I know that right now it's very, very early, and especially we discussed something in colonoscopy where it's not very useful. But in ERCP, I think for identifying the papilla, identifying the papillary orifice, for identifying the direction of the CBD, it may make, I think, a mark there. Now, coming to the second area, bile duct stones. Now we have several techniques, including balloon dilatation, laser lithotripsy. We can do ESWL and so on to remove bile duct stones, variety of techniques. So we don't require any new technique here. There's no unmet need. But what we require now is techniques to predict which patients has a CBD stone, especially in patients with acute biliary pancreatitis. And this is a machine learning based prediction tool, which my colleague Nitin Jeptab published in endoscopy recently, where based on certain parameters with a high accuracy rate using AI, you can now predict which patients are likely to have choledocholithiasis and therefore require ERCP. Similarly, if you get a patient with CBD stone, you want to know whether it's a difficult stone to extract or easy stone to extract. And here again, using machine learning or artificial intelligence, you can predict it very easily based upon the stone size, lower end of the CBD, the angle, and so on. So a difficult stone can then be done by the expert unit, and the easy stone can be done by the registrar or the beginner. I think this is going to be an important tool which we will be using very commonly. And of course, we are trying to reduce our fluoroscopy exposure to radiation more and more. And this is another AI technique that Shyam Vadrajulu and his group have started using to decrease the field of exposure. This is an interesting technique which can be added to any fluoroscopy machine that we have and be used as a part of this. And a part of this, fluoroscopy-free ERCP and extraction of stones are being done. And you can see my colleague Mohan and Sandeep are part of the study, where after a sphincterotomy, the blind guide wire, we can actually then introduce a cholangioscope, and then using baskets that can be passed to the cholangioscope, we can remove these stones. This technology is already available now, and there are many, like for example, Subhash Banerjee only does fluoroscopy-free ERCP now. Similarly, Ken Binmola does only this. So this is going to become more and more common, unmet need that's becoming easy. Now coming to biliary stricture, we have separate challenges for hilar stricture and those for a proximal stricture. Now, one of the most important problem for hilar strictures is indeterminate biliary stricture. For example, if you see strictures like this, it's impossible even with a lot of experience to say which is inflammatory, which is post-operative, which is malignant. And the only way to do this is to get tissue for diagnosis. We have been using brushes and biopsies, but you can see our yield rate is only 50% with this. We are now starting to use a cholangioscope, increasing to 80% and just above 80% using many of the genetic technologies like KRAS and so on. So we still haven't achieved the 100% diagnostic rate that we have with, say, carcinoma stomach or carcinoma colon and so on. So can we do this? Maybe using cholangioscopy and artificial intelligence we can do it. We now have 3 cholangioscopes available in the Indian market currently. Each of them have separate positives and negatives. I don't have too much time to discuss this, but I think one should choose what suits you best and go into this, because in all these cholangioscopes, we can now add artificial intelligence, and based upon this, we can very accurately diagnose cholangiocarcinoma. And you can see the brush biopsies are now 60%. We have reached almost 99% accuracy rate using CNN techniques in cholangioscope. And I think in future, most of us will be doing a cholangioscopic diagnosis of indeterminate biliary stricture. We'll be using one of these techniques as they become more mature and less costly for diagnosing a cholangiocarcinoma. One of the things that's happened over the evolution of ERCP is that plastic stents are slowly going off. They're going to the graveyard or museum of endoscopy techniques. They're being replaced by metal stents, which are becoming better. That or can open up this putting in another stent through, as you can see. And the covering material used to be silicone earlier, but now PTFE has dramatically improved this covering material. And one of the questions that's often raised is that if we have a hilar stricture, how many stents and where to put this stent? So I've just made this chart to
Nagi?
That is where you require the maximum number of stents, maybe 3 stents, 2 or 3 stents. Type 3B will require 1 stent, and type 4 will require 2 stents. It's just, you can remember blindly put this up in your ERCP chart, and then you can keep following this. So when we put in these multiple stents for hilar strictures, we are not sure of the diagnosis, we put a plastic stents. If you're sure of a diagnosis as a palliation, we put in this uncovered metal stents. There have been modifications of these stents to see if we can do better. But what is very interesting is one of the biggest unmet need is can we put in covered metal stents in the hilar region and remove them later? Because you have diagnosis not made, biopsy is negative, but still you think it's cholangiocarcinoma, or it could be autoimmune. After treatment, you remove this stent. Up to now, we haven't had a covered metal stent which can be put in the hilar region. But I think this problem is being solved now. A new stent called the Hiljo stent has been made in Korea, and the trials have already started with this. We have also tried this out. But this is a very peculiar, completely covered stent. But in between the covering and the metal, there is small area where bile can flow through. And these stents can be very easily removed without any problem. So these are completely covered. They are completely removable. And instead of using plastic stents for doubtful cases or benign cases, we can use these stents in future. I think this is one unmet need which seems to be now coming over. Now, the other unmet need is that we just put stents in patients like this, leave them alone, say you die in 6 months' time. But I think we're getting better at this. Now, we're improving palliation by tumor ablation, improving survival, improving stent patency, and so on. A variety of techniques are coming in, but I think the easiest, cheapest, and the most often used is the radiofrequency ablation. And you can see here this technique we described long back, where you can open up these tumors.
Nagi? Unmute.
Can you?
Yeah. Unmute, Nagi.
I am unmuted only.
Okay, okay, okay. Right. Now.
So you didn't hear my talk at all?
No. We heard everything. And
we heard.
Everything we heard, and that the Weinstein covers.
Yeah, last minute or so. Last minute.
Maybe one slide you can go little early.
No, it's okay. It's okay. Then no, I just talking about RFA. I don't know why it went.
Kishori.
So you're getting some cross connection, TSA?
No. This is all right now.
So what is that language that came?
I think that is some language, not anything in India. So okay. That's also
Okay, so,
an international webinar. Okay.
Okay. Yeah. So this has been several randomized control trials showing the efficacy of RFA. But see, the problem with RFA is that although it partly meets some of our needs, there are several problems. One is it's a catheter, and this catheter may not have opposition with the tumor completely. Sometimes a part of the tumor is opposed, some is not. So unfortunately, we cannot visualize RFA as we are doing it. So very often we are giving inadequate RFA, and that's why we look at the results in the literature, they're very variable. And this solution is coming now, and the solution is that we have a balloon RFA, just like for Barrett's, where you can open up and almost always it touches the tumor. And second, we are going to have a cholangioskop guided RFA. So these two things are going to solve the problem so that we can actually do a perfect RFA, which is going to solve the problem. So we have covered, now we come to another area, pancreatitis. In acute pancreatitis or gallstone pancreatitis, urgent ERCP has been a debate. And you can see the large number of studies supporting, not supporting. One of the reasons for this, of course, is that it's a very difficult area to do randomized controlled trials. But to a large extent, this has been resolved now. All the society guidelines say that only reason doing ERCP for gallstone pancreatitis is acute cholangitis. Whether you have mild or severe pancreatitis, doesn't matter, acute cholangitis. In no cholangitis, there's no need for doing ERCP. And other most important advance that's occurred in the area is that in all the patients, we now do a pre-ERCP US to confirm that you're dealing with gallstone pancreatitis before you actually go in. That's the reason why you see now in a suspected biliary pancreatitis, earlier LFT abnormal ERCP, only 40% used to have stones. But now we do an LFT US confirmed 90% will have stones. I think this is a major change of pathways of what we're following in ERCP. Now, the area of pancreas divisum has always been a very confusing area, whether to do endotherapy or not. Many normal people have pancreas divisum. And you can see here that in those patients who have a pancreas divisum with Santinero seal, the chance of a positive result is almost 100%. In others, it is not predictable. Till recently, we have seen and we have shown that patients who have pancreas divisum with an abnormal genetic mutations are the ones who will respond to endoscopic therapy. So it's now we are very clear when to do endoscopic therapy for pancreas divisum. This was a very big challenge, and now I think to a large extent it's solved. For chronic pancreatitis, that is combination of extracorporeal shock lithotripsy, removing the stones. But I think now with these new pancreaticoscopes that are coming in very thin, we probably have the ability of going in and then blasting the stones. And we just have to wait for this very long unmet need to have a pancreaticoscope which can be easily passed through the pancreatic duct. And because next we come to infections and disposable scopes. This has been an area of contention in the Western world, not so much to us. But I think we're producing infections not knowing about this. Unfortunately, although there is a need of using a disposable scope in our country for some patients, it's truly unaffordable. 4 lakhs for a scope is something which is extremely high, although some patients may afford. So we are having all these new types of disposable caps which can be put onto the scope. And we are trying to see whether they're as good as disposable scopes. In fact, what we're required to do as a multicentric study in our country is to actually compare this disposable cap ERCP scope versus a disposable scope. And my view is that they may be as good as a disposable scope with the cost which is extremely low. One study recently done in Thailand showed that the amount of infections that you can get using these disposable caps are dramatically reduced, and they may be as good as using disposable scopes. So I think this is something, an unmet need that we have to watch carefully. Now, this is an area that Randhir mentioned, which I think I want to emphasize, the relationship between EUS and ERCP. Long back, when we couldn't do an ERCP, we used to send these patients to our radiology colleagues who would do a PT-BD. But this has changed now. Now we are sending it to our endoscopic ultrasound guide. Most often, the ERCP guy himself is doing US, so he shifts to US for this. So traditionally, this was actually done first by Mark Giovannini, who in frustration of not getting into a bile duct, actually put in his ERCP scope. He was very good at that and could drain. So we have been using endoscopic ultrasound for failed ERCP. And then came a concept that you could use this for assisting in ERCP. You can't get in, do a rendezvous procedure by putting the guide wire in and using ERCP to complete. But now we have a trend, which Randhir mentioned, that we are trying to do EUS instead of ERCP. So the question is, ERCP, is it dying? Is it going to be replaced by EUS? So because we can get into the bile duct from the stomach or from the duodenum. In fact, in 2013, Moin Kasab wrote an editorial in GI Endoscopy saying, we are prime time for replacing PT-BD with EUS. I agree with that. But the question is, are we now ready to replace ERCP with EUS as a primary biliary diagnosis? 6 randomized studies recently seem to suggest so, based on the data that's available. But I was asked to write an editorial sometime back, and then and even now, I don't think it's still prime time. I don't think EUS is ever going to replace ERCP as a primary modality, mainly because we have to do a procedure to a natural orifice. The complications that can occur with a failed EUS is much more dangerous than complications that can occur with a failed ERCP. And therefore, I think ERCP should still be the primary procedure, not US. Maybe in future, when we get combined scopes like this, a large unmet need, which some companies are now trying to explore to see if they can make a combined US ERCP scope. Now we come to another very critical area of unmet needs, and that is ERCP training. The problem with ERCP training is that ERCP, more than anything else, it should be actually ensuring really competent practice. This should be ERCP. By doing it for the right indication, which can be taught easily, by doing it right, by training and expertise. The problem with ERCP training is, unlike colonoscopy or endoscopy, we don't have good simulators, and that is where we should work at, to produce good simulators, because animal labs that are there, the animal simulators are not very good. Animal anatomy does not correspond with the human anatomy, and therefore this is a large unmet need that we have. We have courses like this, or even mega shows like this, which are supposed to teach ERCP, but they're just shows which don't give you a hands-on teaching experience. Some mechanical simulators like this are coming, but I think they are just, again, very basic. So in my opinion, one of the largest unmet needs today is inability to train everybody properly in ERCP. ERCP is still a 1:1 training, where the trainer stands behind the trainee, teaching him over the shoulder of what to do. So I think this is a problem that is going to be difficult to solve unless you get very realistic simulators to come. Because you're going to get more and more problems. Look at this, altered anatomy is coming in a large way. Enteroscopic assisted ERCP, lap assisted, or US guided gastropexy. All these are going to be problems in future, which are going to be higher end problems, and we have adequate training is important. And one of the areas that is my favorite, I think is very important to look at, is post-ERCP pancreatitis. In fact, this complication was brought to light in 1996 by Marty Freeman, and we know that 10% of average risk and 14% of patients who have high risk develop post-ERCP pancreatitis. Certain new concepts have come in now. One is, of course, that we know that guide-wire trauma is more often leading to post-ERCP pancreatitis than contrast. In fact, there is now a very good study to show that compared to contrast, which we thought was more dangerous, the guide wire is more dangerous for post-ERCP pancreatitis. And therefore, we now come to the conclusion that if you have a patient who is high risk for post-ERCP pancreatitis, more than one pass, put off a pancreatic stent, don't wait. For a standard risk case, more than 3 passes, put off a pancreatic stent. This is now definitely coming into the guidelines, and this is what we should do. There are some predictors, new predictors for post-ERCP pancreatitis that are interesting, and one of this is pancreatic steatosis. So if I have a CT scan done before ERCP and the radiologist reports that this patient has a lot of fat, then I'd be very careful in a ERCP because I know the post-ERCP pancreatitis is higher. And similarly, renalase is a flavor protein which is produced by the kidney. It has been shown that lower renalase levels have increased post-ERCP pancreatitis. So in fact, it is protective. Renalase is protective for pancreatitis, post-ERCP pancreatitis. And this in future may become a routine marker. In all our patients before ERCP, do renalase. If it's high, don't worry, unlikely to be post-ERCP pancreatitis. Similarly, now we have made a pocket calculator, which we published recently, where you can predict. Just put all the data of the patient into the in your iPhone, and you can get what is the chance of percentage. Percentage is high, better to give it to a more experienced person to do. And of course, we now know that a combination of both indomethacin and giving a stent is better than using only one. And fluids, several RCTs showing the use of fluids. There's been a lot of debate about fluid, but I want to make it one thing very clear, that even small amount of fluid has some benefit. So kindly give IV fluids, ringer lactate to all your patients before ERCP. This has some protection during ERCP and after ERCP. In our unit, we give about 3 pints of ringer lactate before, during, and after ERCP. Because now we can, using these techniques in our unit, our ERCP, post-ERCP rates have come down from 9% to 2%. But can we get it down to 0%? Can we get it down to 0? I actually thought about this for a long time. It took me 40 years of meditation, thinking about it, to come to a conclusion whether how we can reduce the post-ERCP to 0%. And now, today, after all the ideas that I got after the enlightenment, I'll give you the magic. I'll tell you the secret. Listen carefully. The secret of producing zero ERCP post-ERCP pancreatitis, just don't do it unless strongly indicated. If you follow this, you won't produce post-ERCP pancreatitis. Most of the time, the pancreatitis is unindicated ones. So just to conclude, I gave you a background of 70 years of journey of ERCP. It started with several unmet needs, but slowly over a period of time, all these unmet needs have been met, and there are few still. And one of the most important one is this relationship between EUS and ERCP, which is going to mature, and our ability to prevent post-ERCP pancreatitis will become very important. Thank you again for your attention.
Thank you, Nagi, for a wonderful lecture as usual. And I fully agree with you that training the ERCPist is possibly one of the biggest challenges and unmet need which we continue to have today. And now that we have some questions which have been asked by the audience, and one is a very interesting question, that if you have the stents of the same size in the PD and CVD, is the occlusion rate different? And
Yes.
and why?
Yeah, so actually, if you look at the stent itself, both get occluded by about, say, if it's 7 French stent by about 4 weeks, 10 French stents by about 3 months. The reason why there's a difference is that in pancreatic stent, the pancreatic fluid flows around the stent by the Wick effect, and therefore the blockage is not manifested. Whereas in the biliary tract, the stent gets blocked, there's secondary infection developing, and these people manifest as cholangitis. The second important thing is that in biliary stents, there's a lot of biliary sludge. Unless in the pancreas, pancreatic stone protein is very high, the normal pancreatic juice does not cause blockages compared to the bile juice, which is very viscid, and because of the character of the bile fluid, the blockage rates are a little higher.
The second is, you already answered, about the need for pancreatic stenting in case you enter into the PD even once. So I think we have to have a very low threshold for stenting of the pancreatic duct. If you are put in a guide wire, then it's best to put in a stent before removing the guide wire, or so that you prevent the pancreatitis. The third is a very interesting question, which is in teaching institutions. There's a hierarchical approach. You are there now. You have a deficiency of time and excess of experience, And there's a fellow who has got all the time his desire to learn, and he's doing the ERCP, and you are teaching him, and you're itching to take over. So what is your criteria for letting him do for how long? What is the objective criteria which you use?
So I think, Randir, that's a very interesting question, and this is something we can discuss for a very long periods of time. I'll just briefly tell you what my thoughts are. First of all, my thought is that we should be clear which trainees actually require. If a trainee thinks that his future career is going to be IBD or going to be IBS or going to practice, I don't think we should or he should be investing his time in trying to do ERCP. Earlier, I was against all trainees doing it, only specialized advanced trainees should do it. But now I'm changing a little because of pressure we get from our trainees, and because I feel that in some places, then you pass out DM, you may not have anybody else to help you. So I think we should now characterize which trainees should be trained into ERCP. Once they are given that training, I would be very careful about which cases are given to them. That is the first. I think here AI, I told you, may be useful. If it's going to be AI predicted difficult case, difficult cannulation, difficult stone, then I think a consultant should start off first. But if it's going to be an easy case, then a student should take over. I would give 10 minutes time. 10 minutes time. I tell also the technician to watch carefully. If the trainee is now manipulating the papilla more than 10 minutes or more than 10 times, we'll take over. There's always important to remember that success or failure may not be a final thing for the trainee, but a failure may be the last thing for the patient. That may be severe pancreatitis and he may finish. So I think that's very So patient is always kept in the background. So select your trainee, select your case, and give about 10 minutes for the procedure.
Nagi, we have a little different approach. What we do is we have a sort of a step-up approach, that we let our trainees first take out the stents which have been put in earlier, so that they get familiar with focusing the papilla, maneuvering the scope, and using the devices. And then we ask them to cannulate the same CVD which has been cannulated earlier, so they have easy access, and put in a balloon, so they get a little familiar with the process.
So Randir, we use the same thing, that you first pass side viewing scope, and after 10 side viewing scope, it's comfortable to take out stents. After that, so cannulation comes as the last phase. The same, same.
So TSC, I think
we will have a lot. Yeah, and Randir, thanks for the nice moderation, but still we are around. But we will have to ask other questions to Dr. Gokul has got a question to Nagi. So Gokul, what is your question?
Sir, thank you very much, sir. I thoroughly enjoyed listening to the lecture today. So my question is, what are the tips on ergonomics? Because most of these procedures takes a lot of strain on your muscles and joints. So what is your tips for us how to avoid the straining of muscles and joints?
So I think the wrong movements are mainly responsible for our movements. For example, ergonomics is a very important aspect. So what you must do is see that your fluoroscopy and the endoscopy panels are on the same side as your head, so that you are watching directly. Many times the fluoroscopy is one side, endoscopy is one side, you twist your neck. See that the height of the table comes to your elbow, so again, very easy to do. Keep a mat always. These thick orthopedic mats are available. Keep a mat always under your feet, because that also helps to decrease. Amount of movement that you do should be very less. All these things very much help. And of course, if you have a gym in your endoscopy, near the endoscopy room, you can ask TSC to set it up. That will also help because in between cases, if you do a slight amount of gym. We are now doing something very interesting. I didn't have time to show that. Now we are monitoring the ergonomics of all the small joints of our endoscopies here. And then we have an AI now which will tell us whether you're doing excess movements or not. So we can actually do this it's very cheap. The cameras are available to follow movements of your body, and you can now put it into AI and actually say that maybe this person is moving too much, you can warn him. Many of us, I don't know, Randir and TSC would agree, we developed cervical spondylosis because our monitor is to very high. And now we know that's wrong, it should be in the eye level. So simple, basic ergonomics, you can avoid many of these injuries.
I think I happened to see you recently constructed a gym. I think you can make a visit of that, and Gokul, you can also create.
I had a quick glimpse of that.
I think, but Nagi could do it after so many years. I don't know whether.
No, it's not. I think it's not the cost factor. Cost is not so much. It's the wisdom that came very late. After 40 years, I got the wisdom. Yeah.
Nagi, the killer slides where the UES failed ERCP, UES assisted ERCP, and UES instead of ERCP. That's a great thing that, and the training is so difficult. Randir nicely put it. We also allow them to just to introduce the scope and withdraw the scope, look at the papilla, and then after that stent removal and other thing. I think most of the units in India they follow this. Dr. Ravi, you have a question to Dr. Nagi?
Yeah, yes, I thoroughly enjoyed the talk, Dr. Nageshwar Reddy. My question is that, do you think anytime soon robotic will come to assist us in cannulation, particularly in cases of periambulary diverticulum, where the the orifice is very much within the diverticulum?
So that's also an interesting question, Ravi. In fact, I think putting a robotic system into a side view scope is extremely difficult because of the various angulations, maneuvers, and all. The Korean endorobotics company has recently come up with an arm which can be manipulated robotically and do this. So I think robotic endoscope won't come, but robotic axaries will come for ERCP, where with the robotic axary, you can manipulate, pull the papilla to one side, and using the same axary, you can cannulate. You can also cannulate in different directions towards the CBD and all. So I think in the future, or maybe in even near future, endorobotics are working on this system. A robotic axary may be possibly coming to us to help us cannulate better. But I think nothing will replace the right technique. That's very important. A robotic endoscope I can't see in future.
Ravi,
I
thank
think
you.
Dr. Surinder Rana has a question.
Yeah,
He raised his
Surinder?
hand.
Yeah. Rana?
Hi, sir.
Dr.
It's
Rana?
always pleasure. Yeah, it's always pleasure listening to you, and there are a lot of things to learn from you always. I think one of the important unmet needs is probably a failed ERCP, which gives a lot of stress to the endoscopist. So my question would be, if you have a failed ERCP, you're not able to cannulate any duct. Would you like to go for a pre-cut or a EUS rendezvous? And secondly, if a wire is in the pancreatic duct, will you do a needle knife pre-cut or a transpancreatic sphincterotomy?
Yeah, so I'll come. These are very important questions, Surinder, because because of time I didn't go into it. But if my wire is into the pancreatic duct, I'll always put a pancreatic stent and then do a sphincterotomy, a pre-cut sphincterotomy. If you look at the literature, it's opposite. I disagree with the literature. Literature says do the transpancreatic sphincterotomy and then follow it up by finishing the procedure and putting a pancreatic stent. I disagree with this, although literature has shown that this is the most effective way and so on. The reason is you're destroying the pancreatic sphincter unnecessarily by using this technique. So my technique is still old-fashioned. I put a pancreatic stent. I stopped doing double guide wire now because after double guide wire also you have to put a stent. So if my guide wire is going into the pancreatic duct after one pass in high-risk cases, after 3 passes in average risk cases, I'll immediately put a pancreatic stent, a single loop pancreatic stent, single pigtail, and then on that I'll do a pre-cut, and almost 100% of the times we succeed. Now, our success rate should not be, in ERCP should not be 99%. It has to be 100%, I think, because when you got up this question of failed ERCP is very often because we are not adapting this pre-cut early on. We go on fiddling for a very long time with the papilla till it gets into the pancreatic stage, very edematous, especially with the axillary papilla. You have to go in very quickly. So I think for pre-cut, we should start very early. That's what I feel. And we should do this technique where if you can't get into the both ducts if you can't put in, then if you have enough experience, free needle knife sphincterotomy is still there. Now, regarding the rendezvous procedure with the US, I believe, again, these are my views, that you should do it only if you have a duct which is more than 12 millimeters. If you have a CBD which is less than 12 millimeters, this rendezvous technique, I think, is exaggerated. I know the very nice article by Jayant and others recently in Annals, which showed that these two are equivalent, pre-cut versus rendezvous. But I prefer the standard pre-cut. If you have a very abnormal papilla, which you can't cannulate, if your bile duct is more than 12 millimeters, then I would very quickly go to the rendezvous technique because that makes it easier. But you must remember, at least the youngsters who are listening should remember that putting a guide wire US and directing it towards the papilla is not so easy. It looks very easy in edited videos or sometimes in workshops when the expert is doing it, but it's not so easy. Very often the wire is going up towards the hilum, and then you start producing all sorts of problems, including bile leak in a dilated duct. So it's very clear. I would do pre-cut as the first option, and I'll do it very early. I always do it on a pancreatic stent. If the duct is dilated more than 12 millimeters, if the papilla has got a very bad anatomy, then I'd use the technique of US random. I hope I answered the questions.
Yeah, I have a question from Rajesh Puri. Is Rajesh there? Okay.
Yeah, nice.
Surendra, anything else? You seem to have a doubtful face.
No. He is fully convinced. Only thing, when you quoted the article, why the literature is you are different from literature?
Yeah, I refer because I think we have more experience than literature sometimes. So I think experience is important.
No. I agree to what you said, sir, because literature says transpancreatic is better than needle knife, but I don't think so. Transpancreatic is.
Yeah, transpancreatic is sometimes very dangerous. Apart from the spoiling the pancreatic sphincter, which you would not like to do that. Sometimes the cut will not be in a different direction. Then chances of complication also very high.
Let's have the next question. Rajesh was going to ask. Rajesh?
Yeah. Rajesh? Nice lecture, sir. So sometime you face the problem in cannulation of the minor papilla.
Yeah.
If you face the problem, what is the trick that you should be successful as you are going through the major papilla? Second question is, in the normal bile duct, in the bile stricture, that is a benign biliary stricture, the literature talk about 5 stents, 6 stents, but in the real life, it's very difficult to place more than 4 stents unless until the bile duct is grossly dilated. So these are the two questions which I need to ask. How to put 5-6 stent and how to cannulate successfully in more than 95% time. Minor papilla.
So minor papilla, Rakesh, I think this is important. Of course, there are several techniques. Again, we don't have too much time to go into this. So what I would do is that I actually put my scope on the minor papilla. The question is first identifying the minor papilla, which we can do many times. But the second question is it's very difficult to identify the orifice sometimes. In most patients who are symptomatic pancreas divisum, we can catch the orifice. But those who are not very symptomatic, or sometimes it gets very small, very difficult. Fortunately, in our department, we have secretin, so we inject secretin. But if you don't have secretin, you can't get it. One of the ideas is to put your sphincterotome slightly out towards the mucosa, so that keeps the papilla away from the scope, and then suck on the scope. So when you suck on the scope, guarding the mucosa not to come towards the scope, you can see suddenly the papillary orifice opens up and a small drop of juice you can see. That is one of the tricks that I use. The other tricks that people have described, like putting methylene blue and seeing how male secretion, which usually doesn't work. But there are occasions, of course, you do everything and you can't identify. So in that case, I would always suggest there's always a technique called another day ERCP. Post him another day, second day or third day, and you'll find that for some reason suddenly you can get it.
Nagi, now
can I ask a question?
Sandeep?
Biliary stents, but I'd say don't try to put in 5-6 biliary stents. Very often 4 are maximum. You can't put in more than 4.
That's what he said. 4. Otherwise, you can go for the metal stent.
Mostly we use a completely covered stent for lower strictures.
And Nagi, that was the most structured talk we have listened to. Now, I'm glad that we selected the topic met and unmet needs. So I was wondering how you're going to do the kind of, you did a fantastic job, and we had a great moderators and other thing. Now my turn has come now, and I'm glad to tell you that I thought it's a technical topic, only very few attend. 745 delegates from 12 countries they were attending now. So it's a great success to listen to the speakers and moderators. Now, my question to start with I think we are done with the colonoscopy and ERCP. Now, I will start with the Nagi. Now, rapid fire, very, very brief. What was your ambition before joining medical college? After finishing DM, and now what is your ambition?
So my ambition before joining medical college was zero, nothing. I was asked by my dad to write this exam. I wrote, I got in, but I had no ambitions at all.
But did you plan this kind of success, or you didn't have ambition?
No. I absolutely no
Okay.
plans.
And end of your MBBS?
At the MBBS, end of MBBS, I was interested in medicine definitely, so I went into medicine. And during medicine, I was very interested in hepatitis B because of Bloomberg, who visited Chennai at that time, and I took gastroenterology because of that.
Okay. Now, when you finished DM, what was your ambition?
So by end of DM, I knew that I didn't have the intellectual capacity for hepatology. So for me, mechanical jobs, the mechanics was easier. So I knew I had hand-eye coordination. So I went into endoscopy, and that time endoscopy was fairly primitive in the sense we had upper GI, colon, and ERCP only.
Do you think there's an understatement? I didn't have an intellectual capacity to choose hepatology.
No, this is a balanced statement.
Okay. And what is the ambition now?
Ambition now is that I've been very lucky throughout, so I hope that luck continues for me. Because
That is your wish. Wish is different from ambition.
No, my wish is that I'll hope
become like a ambition. Huh?
No. My wish is that I hope I'll get an opportunity to create a medical engineering school, because I have some now capacity to do that, where doctors in India are trained in both medicine and engineering, and then that's going to be the future for a country. Develop a large number of medical engineers or engineering medical people.
I've been associated, maybe one of the longest associates I had with you. I remember that we doctors, we work separately from the engineering school.
Yes.
We need to collaborate. That I agree with you. What is the famous quotation that inspires you?
I think for me, famous quotation is what Rajat Gupta once told me when we called him. He was at McKinsey earlier. He was the president. Was displaced later, but he told me a very important thing, which I asked him, what is the reason for your success? And he said that he doesn't have a comfort zone. Whenever you reach a comfort zone, you raise the bar, you increase the bar. And when you increase the bar, you know that you go to the next level. So you may be finishing your DM, you may have a good practice, but doesn't mean that's the end. You raise the bar, then you create an institution. You raise the bar, you create further. So I think we should not reach a comfort zone in our life as long as we're active life. Of course, after you retire is different.
But retirement doesn't come to you, so you will not be comfortable till the end, I think. Okay.
No, I think it's what I also feel that we should take reasonable risks. Not that we should take very unnatural risks again. Take reasonable risks and always increase your comfort zone.
Tell me 3 personalities, just name them, who really inspired you. Okay, my God, I should have still like that, or they really inspires me. Who are they?
In medicine?
Any field. They really inspires you.
Actually, the person who inspired me most was my school teacher. His name was Jim Bray. When I was in Hyderabad Public School, he was a phenomenal character, very liberal character, who taught me the concept of liberalism. So that has carried me throughout my life. The second person, I know it's cliche to say your dad, but my dad was not initially inspiring me, but inspired me when I had a very good practice at Innova. He called me home and told me, you're a big failure. I said, why am I a big failure? He said, you're making money for yourself, not doing anything for others. And that's what changed my life. So that was a very inspiring factor for me. And I think there are several others, teachers in medical schools and all. There are many others.
Okay, we'll give a rest to a few seconds to you. And we'll move on to Randir. Who are the 3 inspiring personalities? Really, my God, they have one really shaped me, or I really listen to them, or who are they?
You see, I've got 2 personalities in front of me.
Okay.
Nagi professionally, and you to learn the gift of gab, how I can conduct a conversation.
Okay, who is the third one? Who is the third one?
Third one is Rajesh Puri, because I haven't met a person who has been as dedicated to his work as he is. I tell you, when he joined, I just had to tell him in the middle of the night, Rajesh,
you take rest.
This is to be done, and he will say it will be done. and he will think how to do it later. And so I really appreciate that attitude, and I haven't found that attitude in many of the people who have been working with me.
Okay, which is the last book apart from medicine you have read recently, which you will advocate?
What?
Any book other than medicine?
I'm a poor reader.
Okay.
So I would recommend a book called Nexus to all the people. Nexus, Nexus, written by Noah, the same guy who wrote Homo sapiens. He wrote a book called Nexus.
Yeah, I got a gift now, Homo sapiens, I think.
Okay. Yeah, Homo sapiens is a fantastic book, but he's written two others, and the fourth book is written now is Nexus, which actually is a integration of how life is going to be in information, like all the social media information coming to us. So much of information is hitting us, so we don't know what is right or what is wrong. And it's a very nice book too.
Thank you, Noy. Randir, I appreciate your presence of mind. You don't have to think about three personalities. You said they are in front of me. Rajesh, which is the famous quotation you like? Famous quotation. Speak, unmute yourself, famous quotation. Okay, well, you are ready. Ravi, which is the famous quotation which you really appreciate? This is very good, and I would love to.
I'm not getting it.
You are not getting the famous quotation? Okay. Who is the personal to...
I want to say one thing. The book which was suggested by Dr. Nageswar Reddy is available in short forms as audiobook in Blinkist.
Okay.
You can read it in 20 minutes time. You can listen to that.
Okay. Rajesh, you are ready with the inspiring quotation?
Yeah, so if you see that by our previous president of India, nothing is possible. Decide and you work hard, then everything is possible.
Right. Nothing is impossible. I am possible. That is famous quotation by the Hollywood actress. Nothing is impossible. I am possible. Famous. Can you anybody know the famous Hollywood actress?
Yeah, but I'm not sure whether that is right, because some things are impossible. You can't become a Modi, for example, however hard you think and want to do. So there are certain things. I think we have to have a reasonable ambition, I feel. That's my feeling.
Sandeep, how did you get into music? Just tell me that. How did you get into music? Sandeep, are you there? Why?
Sandeep
Yeah,
is
yeah.
playing some
Okay.
music I'm hearing.
Yeah. Actually, in the music, actually, during my college days, nobody allowed me to be on the stage for music.
We are only allowing now.
Now everybody allows me now. And the quotations which inspire me are three. One is actually you aspire to inspire others, and just do it. If you do it, then you get it. If you don't do it, you never get it. And third is hum honge kamyab ek din, man mein vishwas. I still actually, day before yesterday, I played a national tennis tournament. So you just do it and you get it.
Oh, just do it. But Nagi said, just don't do it. No complication in ERCP. But I like that. What I like.
Don't do anything heroic. Don't do anything heroic, but just do it.
But this is the first time I'm seeing a Buddha with a mustache. Nagi, I never seen a Buddha in any form. I've seen
actually,
Buddha with a mustache.
Buddha, by the end of his meditation, actually developed a
grows
beard
the
and
mustache.
mustache.
At the end of the
No, he
meditation.
actually grew everything, but fortunately, pictures don't show that.
Rana, what is your famous inspiring quotation? We are coming to the end of it.
Sir, by APJ Abdul Kalam, which he very beautifully said, to shine, you have to burn like a sun.
Okay, light. You have to be light. Mr. Jairaj, what is your famous quotation?
My famous quotation is, life is like riding a bicycle. If you want to keep a balance, keep moving.
Keep moving. I think that is very good. I think if you don't move it and you feel that, okay, you may fall down. Gokul, what is the famous book you recently read?
Sir, I recently
you didn't give me time to read. All in Med India. What is the famous book you read?
Sir, I recently enjoyed reading that book, Alchemist by Paulo Coelho. It was very good, actually.
Very
how to
good.
realize your dreams. Yeah.
Where do you get time to read like this? When you, that means you should utilize him more better, I think. Okay, who is your famous sports personality, Nagi, and who is the famous film personality?
So my famous sports personality is Roger Federer.
Okay.
I think I'm a big fan of Roger Federer.
Mm-hmm.
So I always, I think he's got grace, he's got humility, which is very important. I think humility is very, very important aspect.
I see that the kind of humility now you are posing now also. Hands folded. And what is the famous film star?
Film star, my favorite is Rasmika Mandana.
Mandana. I know.
What happened to Deepika?
I think she is probably the best actress now in
No,
both
Nagi, what happened to
Hollywood,
Deepika?
Bollywood, everything.
I'm glad that you said that what you told me 1 week before the same thing. And Randir, who is your famous singer in Hindi?
Singer.
The
You know,
popular
I still like listening to Talat Mahmood because I like his voice, I like his tenor, and so I'm an old timer, so I like Talat Mahmood still.
Rana, who is your famous
Mukesh.
actress? The film actors you like? Do you see movies, Rana?
No, sir, I don't see movies, so I can't answer that question.
No,
No,
you
you
can't
don't
answer.
have to see movies to have a favorite film.
Who is the Rajesh? Who is favorite actor? Not actress.
Rajesh.
Rajesh is
Amitabh Bachchan.
Amitabh Bachchan. Okay, now coming to the end of it, I think we had a wonderful session, and the colonoscopy by Dr. Rex was, and you just see the American Journal of Red Journal, the whole editorial on that, and everything on the colonoscopy. The first slide itself, he told it very clearly, withdrawal time and other thing. A fantastic talk he gave us, and he really demonstrated how to do the J maneuver in the right colon. That was the real thing, followed by the talk which we had given to Dr. Nagi, the most difficult unmet and met, and he beautifully narrated with the kind of structured talk. We really enjoyed it. And the last slide was the thing with the Buddha with the mustache and the US insta of ERCP, all these things fantastic. And Randir moderated beautifully, and all your panelists and our panel did a fantastic job. Now, as of now, 763 delegates are watching from 12 countries, and that is the thing of talks about we have a very good international standard speakers and the moderators, panelists. We look forward next time going to be a different topic, fecal microbiota transplantation and probiotics we are going to have in January. So we'll all gather there to meet. Okay. Thank you very much for this wonderful evening. Thank you, Nagi.
Thank you.
Thank you, Ravi.
Thank you. Good night.
And our international ambassador, national ambassador. Thank you.